Hi, and welcome to Rapid Medicine Episode 2. In this episode, we'll be discussing high-yield oncology topics that you'll for sure see on test day. Sit back, grab a juice box, and enjoy the content. Question number 1. A 45-year-old man with a 40-pack year smoking history presents with hemoptysis and hypercalcemia on labs. Chest X-ray reveals a central mass. What is the most likely diagnosis? So the answer that you're going to be looking for on test day is squamous cell carcinoma. Without a doubt, lung malignancies will show up on board exams and both shelf exams. So in the question, anytime you see anything greater than 20-pack year smoking history, that is definitely something to clue in on. This guy is also presenting with hemoptysis, so he is coughing up blood, and hypercalcemia. Hypercalcemia is the dead giveaway that differentiates squamous cell carcinoma of the lungs from other cancers within the lungs. So three things that you definitely want to remember for squamous cell carcinoma is it is a centrally located mass. It is always associated with smoking history, and keratin pearls are seen on histology slide. This is a big buzzword for all squamous cell cancers within the body. And one major important fact that you must remember is paraneoplastic syndrome of squamous cell carcinoma is that it secretes what's called PTHrP, or parathyroid hormone related peptide. And the PTHrP is what actually causes the increase in calcium levels. Just like normal PTH within the body causes hypercalcemia, this can also manifest in that way. Question 2. A 45-year-old man with a 40-pack year smoking history presents with hemoptysis and low blood osmolality on labs. Chest X-ray reveals a central mass. What is the most likely diagnosis? So the answer to this question would be small cell carcinoma. This almost is the exact same question that we had on the previous slide, except for the fact that it says low blood osmolality. With squamous cell carcinoma of the lungs, you're looking for high levels of calcium due to PTRHP as the paraneoplastic phenomenon. With small cell carcinoma, you're going to look for high ADH levels, which are going to manifest as low blood osmolality. This can be shown as a set of labs, or they may just give it to you indirectly within the question, but it will be in there somewhere. Or it can manifest as increased levels of ACTH, which will show up as Cushingoid-like syndrome. And in rare cases, they may throw on Lambert-Eaton syndrome, but it is not as common as the other two. And four things to remember in regards to small cell is it is also centrally located, just like squamous. It is always associated with a history of smoking, just like squamous. The histology is different. These guys are going to have small round blue cells. And high yield fact to know is with small cell, you always want to treat with chemo. Do not do any type of radiation, and do not do any type of surgical intervention. The first step in treatment is chemo. Question number 3. A 45-year-old man with a 40-pack year smoking history presents with hemoptysis and high cortisol levels on labs. Chest X-ray reveals a central mass. What is the most likely diagnosis? So the answer here is small cell carcinoma. The previous two questions were written in a way to show you that each of these high yield facts are important to distinguish each cancer from one another. So in this question, we only change high cortisol levels, and high cortisol levels are due to the paraneoplastic phenomenon created by small cell due to the increased ACTH levels. So once again, small cell carcinoma can secrete high levels of ADH and ACTH, and it can also present as Lambert-Eaton syndrome. Question number 4. A 40-year-old female with a 6-week history of morning headaches comes to the ED for altered mental status. CT imaging reveals the following image. So here's the image. What is the most likely diagnosis? And the answer here is going to be glioblastoma multiforme. This is also known as a grade 4 astrocytoma, and this is a very high yield image to remember. This can be easy points on test day. And here's the things that you want to remember in regards to GBM. So GBM will always cross the midline on tests, and when it crosses the midline, it usually crosses through the corpus callosum. That could be an anatomy related question. And as you can see in the image here, it almost looks like a butterfly. And in the question somewhere, they might throw in, within the mass, there is necrosis. This can be a very helpful hint in deciding which answer choice to pick on test day. Question number 5. A 62-year-old male presents with a non-healing ulcer of 4 months on the left side of his tongue. A biopsy was taken that revealed squamous cell carcinoma. What pathogen is most likely responsible for this cancer? And here's an image of what this looks like. And the answer that you're looking for is HPV 16 or 18. HPV stands for human papillomavirus, and that's numbers 16 and 18. So the big high yield fact you need to remember is the majority of squamous cell cancers found in the head and neck usually arise from HPV. That is definitely a high yield fact that you want to remember. Next question. A 44-year-old female has returned for a 6-month follow-up post-thyroidectomy for medullary thyroid cancer. What tumor marker do you want to order to assess for possible cancer reoccurrence? And the tumor marker you want to order is calcitonin. So the big thing about medullary thyroid cancer is it can be associated with MIN2A and 2B. The way you want to treat medullary thyroid cancer is via thyroidectomy, and you always want to monitor reoccurrence with calcitonin. Do not forget, medullary thyroid cancer is always monitored via calcitonin. High yield fact to know. Question number 7. A 31-year-old female presents with episodic anxiety and feelings of her heart is going to be out of her chest for the past month. Her current blood pressure is 188/102, and she is severely diaphoretic. What is the first step in diagnosis? And mind you, we are in the oncology PowerPoint. So this lady probably has a pheochromocytoma. And the first thing you want to do is you want to measure the amount of metanephrines within the urine. If the metanephrines are high, this is indicative of a pheochromocytoma. If the metanephrines are low, you've basically ruled out there is no pheochromocytoma present. So the things that you want to remember about for pheochromocytoma is that it produces epinephrine from the adrenal medulla. The treatment for a pheochromocytoma is surgery, but the big board question that you want to remember is before surgery, what do you want to do? What you want to do is you want to give what's called phenoxybenzamine, which inhibits alpha-1 receptors and decreases the patient's blood pressure. And you want to remember that pheochromocytomas may be seen in von Hippel-Lindau syndrome, MIN2A and MIN2B, and neurofibromatosis type 1. Next question. A 29-year-old female was recently diagnosed with papillary thyroid cancer. What is the greatest risk factor for the development of this cancer? So the answer here is previous radiation exposure to the head and neck region. Step 2 bombards you with all kinds of different risk factors, and they are all extremely important. And this is one that I would definitely store away for board exams. So with just this image here on the left, what would you say the diagnosis is? So I'm hoping you're saying these are hour rods that you're seeing here. And if you see hour rods, I want you to think acute myelogenous leukemia. It should just be bam, bam, bam. If I see hour rod, I see acute myelogenous leukemia. This can show up on any type of board exam that you're taking, the internal medicine shelf. It is extremely high yield image to remember. And 3 key facts that you want to remember in association with acute myelogenous leukemia are that they're associated with the hour rods, which you see right there, And these hour rods can predispose someone to DIC, or disseminated intravascular coagulation. And the treatment of choice that you want to pick on test day is all trans-retinoic acid. Next question. A 62-year-old male has been having painless hematuria for the past 2 months. He receives a diagnosis of bladder cancer. What is the greatest risk factor for bladder cancer development? So the answer here is smoking. Notice that this is an older individual who is having painless hematuria. So hematuria just means blood within the urine, and it's painless. If you see painless hematuria in an older person, I want you to think bladder cancer, especially if they give you some type of a history where it's a 50-pack year smoking history or a 40-pack year smoking history. Without a shadow of doubt, the greatest risk factor for bladder cancer is smoking on test day. Very high yield fact to know. Next question. An 82-year-old female presents with recurrent bone pain for the past 3 months. Labs reveal a creatinine level of 6.2, a calcium level of 13, and a hemoglobin of 8.5. What is the most likely diagnosis? So the creatinine level here is elevated, the calcium level is elevated, and the hemoglobin is decreased. So what are you thinking? So with this person's age and her constellation of symptoms, I'm thinking multiple myeloma. And these are some important facts that you want to know about multiple myeloma that can get you just about any question on test day. So multiple myeloma is a disease of the elderly. If you're seeing someone who is less than 50, I would not be picking multiple myeloma. You want to remember the CRAB mnemonic. That stands for hypercalcemia, renal dysfunction, anemia, and bone pain. The first step in diagnosis is what's called an SPEP or a UPEP, and those stand for serum protein electrophoresis or urine protein electrophoresis. And the way to confirm multiple myeloma is you're going to take a bone marrow biopsy and you're going to be looking for an increased number of plasma cells within the bone marrow. So question 13. A 55-year-old male with a history of HIV presents to the ED with recurrent headaches and altered mental status. CT imaging reveals the following. There's a CT image there. What pathogen is most likely responsible? So what you're seeing here in the image is a single ring-enhancing lesion in the right side of the brain. And notice that this person also has a history of HIV. So the pathogen most likely responsible is Epstein-Barr virus. And what you're seeing here is what's called primary CNS lymphoma. Okay? A single ring-enhancing lesion in an AIDS patient always think CNS lymphoma. If you see multiple ring-enhancing lesions, you want to be thinking toxo. And just a fun fact, if you see this, this is most likely a step 1 question. This can be the first signs of AIDS in a patient. Next question. A 14-year-old boy has been experiencing pain just superior to his left knee. The pain seems to increase during the night. An x-ray of the knee is taken. Here's the x-ray. What is the most likely diagnosis? So notice that this is a young teenage boy whose knee is hurting more during the night. This is a very helpful hint on test day that is cluing you into some type of cancer pathology that is either starting in the bone or has metastasized to bone. In the image to the left, what you're seeing is what's called a sunburst appearance within the bone. So the answer here is going to be osteosarcoma. So a few things that you want to remember with osteosarcoma is the sunburst pattern, or this thing called a Codman's triangle. If you do not know what that looks like, I would encourage you to look that up. Osteosarcoma is going to originate in the metaphysis of long bones, usually the femur, as is in this case. And it can be associated with retinoblastoma, or in rare cases, patients who have Paget's disease. And the patients who have Paget's disease, you're going to be thinking about an older individual around 60 or 70 years of age. And our last question. A 25-year-old female comes to the office complaining of blood-tinged discharge from the right nipple. Upon examination, there are no masses or lymphadenopathy present. What is the diagnosis? And the answer is intraductal papilloma. I've seen this question multiple times in many different Q banks and on many different exams. The key difference that you want to make when you're thinking about intraductal papilloma is, are there any masses and is there any axillary lymphadenopathy? In this question, there were no masses and there was no lymphadenopathy present. If there is bloody nipple discharge with a mass or lymphadenopathy, you want to be thinking carcinoma in situ. If a diagnosis of intraductal papilloma is made, this is just a benign process and there is no intervention that is necessary. Well, that's going to wrap us up here in episode 2. I hope you guys enjoyed. Please leave a like, a comment, and subscribe. We'll see you in the next episode. Happy studying.